much. So I'd like to thank you, the organizer, for this great opportunity. It's a pleasure for me to be here and to share with you some of the information. And I'll try to be updating on what would be the current terminology that we should all use for the urinary tract infection. And the second part of the talk will be talking about a bit of how the patient need to be assessed to start going through the diagnosis. So to start with, I'd like to say what is we expect the function of bladder and bowel. Obviously, the two have a different purpose. Bladder is more as a cycling organ that stores and voids, while the rectum is more of a transit organ. So you will see passages of feces, and both of them share the connection and the innervation from the spines, which make the two very, very related to one each other. And of course, we never have to forget one when we talk about the other. This is quite a key message. Talking about the bladder, we talk about a couple of main purpose function. The first one is going to be the storage. So we should be able to have adequate capacity, which is maintained into a low pressure. And normally we count as a 15 centimeter of water as the pressure that we consider as a safe. And also to present with a competent sphincter, which will allow the dryness. Of course, the second part of the function of the bladder is the voiding. So the moment we are willing to have a discrete voiding, which should be efficient, should be complete, so not leaving any residual. If it doesn't work, we're going to be the two possible consequences of a non-functioning bladder is either urinary incontinence or renal damage. And meanwhile, the first one is more of a social problem. We count the renal damage as a significant medical problem, which then leads to quality of life. With regards to what is expected to be a normal bladder partner, we have the formula of expected bladder capacity using the age plus 1 times 30, which doesn't even apply for the little infants below 2 years. In that case, we use the kilos in weight times by 7. And then we define if a bladder is small or large compared to the expected bladder capacity as less than 65% or more than 150%. We normally expect a nocturnal production of urine, which exceeds the bladder capacity expected by 130. And again, in the normal child, we would expect the continence to be fully achieved by the age of 5. With regards to voiding, again, we can define the normal pattern of voiding as frequency, which is range between 4 and 7 times, with a voided volume that should allow minimal residual, but it changes with age. So normally we expect a child between 4 and 7 to allow a larger volume. And in fact, abnormal volume residual is counted when that is repeatedly measured more than 20 centimeters. Meanwhile, when the older child should be a more efficient bladder emptying, so the level used as a cutoff is lower. Back to bowel. Bowel also should have a normal elimination pattern. We should see daily or every other day elimination of the stools. Stool themselves, we classify within a Bristol stool chart as per type 1 to type 7, and should be around type 3, type 4 to be counted as a normal. Once again, in terms of reaching the continence, we should expect this to be achieved by the age of 4. And you can see on the right-hand side, we have a couple of ways to assess the pattern of the bowel function, either with some contrast and X-ray, or even with ultrasound scan, which allow us to see a large rectum behind the bladder, which in fact is pushing the bladder from the back. And this is significant in most of our patients with problem with wetting. In 2006, the International Children Continence Society published its first article where wanted to propose a standardization of terminology, and this has been eventually revised, and updated version of the paper have been published in the beginning of the 2010, so 14 and 16. So why we have this article and why the society pushed for that? The standardization of the terminology is a necessary way for the different specialty involved in the care of the patient to talk each other. Sometimes we do not use the same language, and therefore it's more difficult to collaborate and to have the best care for the child. This also is present with regards to our adult colleague. I know that many of adult urologists are managing the patient, and even that society, ICS, has proposed terminology which in some way different from the International Children Continence Society. And finally, why we should have a standardized terminology is because this is also the way for us to compare the results, to look for scientifically and critically revision of the results, which then lead to improvement of our scientific evidence. In terms of definition, what the ICCS has come up with is a setup of terminology and definition. The first one I like to mention is what we define now as a bladder and bowel dysfunction, which is the concomitant presence of dysfunctional bladder and disturbance of the bowel. It was previously also called dysfunctional elimination syndrome, but this should be not used anymore. This is now ideally outpatient. Other symptoms, other definition can be divided between storage or voiding symptoms. With regards to the storage, we call urinary incontinence as an involuntary leakage of urine. And as we said, we normally consider this in a child more than 5 years of age. If there is incontinence, incontinence itself can be divided in different types of incontinence, either if it's a continuous incontinence or if it's intermittent incontinence, and whether occur during daytime, during nighttime. And again, this is another of the usually misused terminology. So enuresis refers to nighttime incontinence. Many times I read also articles that talk about nighttime enuresis, daytime enuresis. This should not be utilized. And so we talk about daytime incontinence and enuresis as referring to the nighttime. Also, incontinence can be divided based on functional or pathological finding, and also this leads to different diagnoses. The most commonly congenital can be leading to neuropathic or anatomical structure as a pathological problem, or the dysfunctional voiding is something that we have under the umbrella of the functional incontinence. With regards to other definition from the society, we can have the urgency, which is reported as a sudden and unexpected experience of needed to void. And this again is in children that have already completed their potty training. So there's not urgency that we can define in children that have not yet completed that. With regard to voiding, we were saying before, we define the voiding between 4 and 7 as our range of normality, and therefore, if it's below 3 or more than 8, then become as a decreased or increased voiding frequency. With regards to nighttime, we also define nocturia as the need to wake and void during the night. This is a very common presentation, and this is in a child which does not wet the bed, so it's actually wake up to go and void. With regards to the voiding part, so the symptoms could be the hesitancy, which we define as the difficulties in initiating the voiding, even if a child feels that is ready to do so. Also, we can have children that strain. So straining is defined as the need to make an intense effort, trying to increase the intra-abdominal pressure in order to maintain and initiate and maintain the void. So all those definitions also initially lead us to what we think is going to be the diagnosis. So define and utilize the correct terminology is the first step toward the diagnosis, which I will come to show you later. Is also defined as an intermittency, that situation where the micturition is not continuous, but comes as a discrete stop and start. And this also is immediately pointing us to a possible diagnosis. Dysuria is a more generic definition of any complaint, any burning, any pain, any discomfort that the child experienced during the micturition. Going to other, so I couldn't just cover them all, it would be a boring list, but all the maneuvers are defined from the society, the presence of spraying, retention, post-micturition dribble, all those are definitions that are made with the purpose to guide the clinician and also to unify the way you describe and treat the child with those symptoms. In regards to the second part of my talk, we are asked to talk about the initial assessment and how you deal with the child that presents with lower urinary tract symptoms in the beginning of the assessment. So what is immediately thinking is that history taking is a very precious source of information and is very important. And the message I like to share is that it is also very crucial in the way to bond with the child and the family. So we strongly suggest to engage with the child, engage with the family, and try to also direct the question to the young person, of course, age depending, if his child is capable to answer the question. So we could make a specific question. We could ask, tell me what is that you are annoyed about. Many times, and you probably will be aware of, children are not bothered, they are wet, so what? And that is, of course, making the frustration of the family and, in a way, the frustration of the clinician, because they never say, I don't feel, I just found myself wet, I didn't feel. And this is also reported by the parents. The parents tell us, well, never say that he needs to go, and then at some point come to me and say, I'm wet, or not even that. Sometimes parents find the child being wet or being leaking without the child itself taking any action. Also, the parents will make observation, so we can explore with the parents themselves what is the normal observation that they make. Is the child living to the last moment, which is obviously very common? Does he know that he's coming, or is he telling us that he just know at the very last minute? And once we cover this initial, we also have to bear in mind possible comorbidity, something that not necessarily is disclosed when you have a referral and when you have at the first encounter with your son, with your patient. So, as I said before, constipation is extremely important, and it's very, very important that we explore that. As much as we need to understand whether there is coexisting of other systemic symptoms that may point out toward the presence of infection, underlying condition like reflux or behavioral disorder will be very much related to a child that presents with a lower urinary tract symptoms, and this has to be taken account in our holistic assessment and of the patient. One thing that also I will strongly suggest is that we contextualize the question and we make the right question. Of course, another limitation of the assessment is the time. We don't have the luxury to spend 2 hours talking to every child. So we need to make the right question to come to the answer. And often the question to make is not that obvious to the family, but has to be obvious in our mind. So we need to understand simple words to gather as much evidence as the problem. So talking about what severity, understanding how often is the leak occurring, when does it then lead to small patches of the pump, does it need the child to be changed, and how many times during the day. Many times we will notice a difference in the pattern of the symptoms at home versus school. And that's also a point toward the possibility that maybe the behavior of the child at school is different from the one that is at home. Obviously, school, they are busy. The teacher cannot just supervise them as the parents do. Another important understanding is to find out whether the child has never reached continence, has always been wet, or maybe there was a period of time where there was perfect and then the symptoms occurred. So we call them as a secondary incontinence. We said before, the time of the day. Sometimes we will have daytime, nighttime, or both. And also we can just consider the behavior of the child. Many times children at this age develop a kind of phobia or fears of of the toilet, so they are not really keen to go to the toilet. So that is also a very important aspect that we have to factor in our process of information. In terms of more contextualized question, we can go straight to the point and maybe ask, is there any specific moment where the leak occurred? Maybe when the child is sneezing, is coughing, is laughing, is jumping on the trampoline. All those will then point us toward the direction of the assessment that we should take, and perhaps also the treatment, as we will see later. In more direct terms, we will be needing to explore the stream. Is the stream described? Another thing that I always say to my registrar, which made me a little bit upset when you ask, how is the stream? Stream is normal. I would define the normal, and each of us will have a different definition of normal, and in particular the patient. And if somebody has always been in that way, that is the normal, but that way doesn't mean anything. So it will be more specific what normal is. Normal means is thin, is thick, is very projectile, you get the toilet, it doesn't get it. So have the information as more precise as possible to guide you toward the possible diagnosis. Physical examination will be my next step. So don't forget that many times the problem is so simple. Of course, abdominal examination will be informing us of the presence of any masses, in particular on the left abdomen, which will be suggesting the presence of constipation. But also sometimes you have simple examination which is missed. A boy with phimosis or a BXO, a girl with a loaded adhesion. I didn't put in this slide, but another very surprising examination that I come across sometimes, unfortunately, boys with a distal hypospadias, which have been told that hypospadias is cosmetic. You don't need to. You can just go ahead and live your life. And then eventually they have a pinhole meatus, which was missed. And the pinhole meatus is actually this stricture that cause all the dysfunctional voiding symptoms. Of course, we're talking about the front, but equally we don't have to forget the back. That's also a very commonly missed examination, which will be very frustrating if it happens in our clinic. So many times the back is the bell that rings and tell us that there's something that we should be aware of. Not obviously is always that evident, like in the top slide, but sometimes it's just subtle, some asymmetry of the bottom or some kind of line, and this also has to point us toward the direction that maybe there's something at the level of the spine that we have to consider. Going forward, we will then move to some investigation. I'm not covering very detail because I'm conscious that that will be part of next speaker. I just wanted to mention what kind of investigation we can then immediately consider. And again, back to definition, urodynamic, what we define as a urodynamic is an investigation of the lower urinary tract dysfunction. An investigation, which could be simple, could be complex, could be non-invasive, could be invasive. We talk about functional test, okay? We talk about the way the bladder and the system of the muscle are functioning. And also the investigation should be then contextualized of the present of the patient itself. So we have a general information which has to be taken in the context of the patient in front of you. Simple to start with will be a bladder and bowel diary, precious source of information. We will know in what should be the most close to the normal setting, because ideally the bladder bowel diary should be filled in a normal setting. You should know how the patient drink, how much, when in the day. Is a patient who doesn't drink throughout the day and come and is thirsty at night and therefore is struggling with anoresis. And this is a simple way to improve. You will be exploring the frequency, the volume. You will have an estimation of the bladder capacity because of the avoiding volume and so and so. Moving forward, following the bladder and bowel diary, there are the simple urodynamics, which can be divided into non-invasive and invasive. As per non-invasive, of course, we can consider the uroflow, we can consider the ultrasound post-void, we can consider the EMG. And with the invasive one, we go a little bit more sophisticated with the use of catheter, with the use of rectal probe, we can see that you may have a facility where the table can be moved and can be changing the position of the child from supine to rector. There are different types of urodynamic. You can do it artificial feeling, you can do ambulatory, you can do it invasive, you can do video urodynamic with the help of the fluoroscopy that will match the urodynamic traces, and the imaging of the bladder will explore the presence of the reflux, will explore the presence of bladder neck, and so on. I just want to say that all those that we said before, so are the pillars of our conducting patient management. We take the history, we do the examination, we consider the assessment, and then we put together, and then we should come with a diagnosis. That is the aim of our purpose clinic. And I just want to mention some of the diagnoses which we commonly encounter. And again, back to my previous talk about the way we define them. Overactive bladder could be called unstable bladder, irritable bladder. Please do not. So we should go away from them. We should clearly define overactive bladder in the way we define the condition. About this, just is a busy slide, but what normally we recognize associated with the overactive bladder is if you do the cystometry, you should have this continuous, so this intermittent signal that you can describe. The child present with urgency, possibly leak, and then we have occasionally small bladder capacity, because this is a bladder that continuously contract and doesn't develop and doesn't relax. Another possible definition, another possible diagnosis that we can make is dysfunctional voiding. This again is a very difficult for some perspective diagnosis to make, and the function that you can see on this top left is that the normal voiding should be a relaxed bladder, which then eventually contracts, and the sphincter complex that relaxes. On the contrary, we do have the sphincter that is highly active during the voiding phase. This is defined the dysfunctional voiding patient. Another definition of another diagnosis could be underactive bladder, and again, this sometimes can be called lazy bladder or floppy bladder. Please do not. How we define underactive bladder is a bladder that generally is associated with large and largely incomplete emptying. Could be end of a spectrum. Sometimes very active and high pressure bladder can eventually lose its contraction and become an underactive bladder, or sometimes we can have a child that starts with an underactive bladder for some problem regarding his development. Other possible diagnosis that we can encounter is post-void dribbling, and this can be in boys or girls. Girls normally should be explored, and a mindful thought should be given to possible presence of vaginal reflux. So again, this will be the position of the child. We will be having a child that interestingly get the leak a few minutes after having done the void, and this is just the mechanism of the void. And you can demonstrate the vaginal reflux doing a video urodynamic, for instance, of a child. Maybe can be a syringosole, or can be underactive bladder as well. We don't have to forget there could be an anatomical obstruction. So you might have that the urine is not coming in the normal way because the system is not allowing to, and this can be functional. And now we're pointing to the direction of the dysfunctional voiding again. You can see on this slide that there is a flow, which actually is not too bad, but is associated with a very highly represented signal. Or on the contrary, we can have a mechanical, and posterior valve is our first and foremost diagnosis. Back to the bladder neck dysfunction. Bladder neck dysfunction itself could be a diagnosis, and you can see on this slide that during the voiding, the bladder neck doesn't relax, doesn't open. You can see in this video, if I can play it, that the child is passing urine. You can see contrast passing from the bladder to the posterior urethra, but there's never passage of a good decent amount of opening at the level of the bladder neck. And eventually at the end of the void, it generates the pressure, which then opens up in the reflux. So bladder neck dysfunction is another important diagnosis. We can have primary or secondary bladder neck dysfunction, and I guess that we will see also in the case later on treated. Vigor incontinence is another very common and easily to diagnosed condition. Easy to diagnose because it's typically happen associated with the laughter. Is easier to get the diagnosis than to treat, because unfortunately we have not such a great capacity. We know that can often be very sudden and large accidents, so the child is in much distress. Could be linked to cortical problem or the way the brain talk to the bladder, and in fact some kind of treatment that are considered and proposed work at the level of the center rather than at the level of the bladder. Volume postponement is another interesting diagnosis, which is generally easy to treat because this is more behavioral. So generally the child is too busy. He's too into what he's doing, watching TV, playing, reading, and therefore just ignore the signal. So his bladder and maybe tell him or her, you need to go. But this message never come to conscious because it's not the important one at the specific time. And therefore then present with leaks, or therefore present with urgency or urgent continence. Interestingly, when we then assess this child normally has normal bladder capacity, normal function. So the function per se is okay. It's just the behavior and the attitude of the child that leads to the problem. We can also define stress incontinence, where you might clarify that there is involuntary leak of very small amount of urine, and you can demonstrate that on urodynamic. Sometimes you can see that the bladder neck descend. This is in a female patient, and therefore this is something that is associated with increased abdominal pressure, such as in coughing, sneezing, or using the trampoline. Okay, so I'm coming to the end of my talk, and I just want to say a very simple take-home message. Please, the importance of the correct terminology, which will empower us to have the best care we can offer to patient. The way that we should follow when we assess the patient is through a systematic and structured follow from the history taking, from the examination, and eventually from the assessment that can be non-invasive or invasive. Thank you very much for your attention.